So we have covered almost all other ions, and phosphate is left. So we will just try to do phosphate today. Have anyone of you got experience of handling any problems related to phosphate imbalance? Yes, Dr. Dora.
Yes, occasionally patients in the ICU have low phosphate, so we need to supplement.
Yes, so whenever like you are uh, any delay in weaning, so one of the hidden cause may be hypophosphatemia. So whenever we are just trying to find out any cause, or we are trying to probe what is the probable cause of delay in weaning, so one of them is phosphate. Okay. Just a second. So phosphate homeostasis is important with reference to, because which is the powerhouse of our cell? Yes. Okay, who will tell? Mozama, what is the powerhouse of our cell?
Mitochondria.
Mitochondria. And one fact which is not like, I will just share with you something about the greatness of mother. Do you know that when there is like fertilization occurs, there is mitochondria of sperm is in the tail, so it does not like enter the ovum. So the mitochondria of ovum has DNA and it replicates. So all of us have our mitochondria, which is from our mother, not our father, because otherwise everything we have 50% participation is from mother and 50% participation from father. So this is just with reference to phosphate and with reference to ATP and with reference to mitochondria, that all human beings, they have, I'm not sure about the other animals, but for like human beings, we all have our mitochondrias, which are from our mother. Okay. So that's why mothers are the most precious thing in the world. Okay. So anyways, so phosphorus is important for any all energy metabolism, cellular signaling, like ATP formation. It is like it has phosphate has it is PO4. Okay, so it has 4 oxygen atoms and central phosphorus atom. Okay, so it's negatively charged. It is also in the phosphate buffer system, which is also part of buffer system in the bones. Okay, we take it in the either organic or inorganic form. Mainly, it is inorganic, and then it is absorbed in the duodenum and jejunum. So any problems related to it will cause problems. Okay, and then it is regulated by vitamin D. The absorption is all affected by vitamin D. Okay. So these are some basic facts. Again, and vitamin D has the role. Vitamin D and any problems when vitamin D is not adequately functioning, then vitamin this phosphate absorption will be decreased. Okay. So Okay, I will just jump here to the causes first. Usually, whenever there is a problem, it is related to either absorption or renal losses, as we discussed about almost all of the this electrolyte imbalance. Okay, so as we discussed that whenever there will be decrease in phosphate levels, there will be problems related to cellular metabolism, and it will lead to respiratory muscle weakness, arrhythmias. So there will be so many problems which will be related to hypophosphatemia. Okay, like as insulin does, so in everything, like it is putting the ions, electrolytes intracellularly. So that is one of them. Again, epinephrine, almost similar things. Drugs like beta 2 agonists and high carbohydrate infusions. Respiratory alkalosis. Respiratory alkalosis also lead to hypophosphatemia. Okay. If the patient is on mechanical ventilation, this thing should also be considered. Okay? And this is also the refeeding syndrome, which occurs because of prolonged fasting and or prolonged after suddenly if feed isn't started, then it can occur. Okay. Renal losses with reference to diuretics and antivirals, glucocorticoids, steroids. Okay. Any like decreased absorption will be related to any malabsorptive problems. So whenever there is any malabsorption problems, phosphate levels will be decreased. Okay. And with the reference to antacids and chronic diarrhea. And as I told you that vitamin D is important for the absorption of phosphate. So if it is not there, then it will lead to hypophosphatemia. Okay. So these levels are maintained by what will be the effect of parathyroid hormone. What is the effect of parathyroid hormone on phosphate? Its response is just like calcium. So whenever there is hyperparathyroidism, it will lead to
Reabsorption.
reabsorption is not because of parathyroid hormone. Indirectly,
Sir,
it is.
control.
Indirectly,
Indirectly.
it is. Indirectly, it is.
Yes.
Indirectly through vitamin D. Okay. So that is okay. Okay. So what may be the causes of hyperphosphatemia? So hyperphosphatemia and any conditions in which tumor lysis syndrome, like in they when there will be some lysis in the body, like it is because mainly phosphate is in the bones. So any condition in which this control is not there. Similarly, in CRF patients, there is hyperphosphatemia, and it also leads to binding of calcium. So it lead to hypocalcemia as well. Okay. So these are some causes of similarly as so what will be the effect of just a second, hyperphosphatemia will lead to just a second.
Arteriosclerosis and
There,
calcium deposition.
yes. What else? There will be tetany, muscle weakness, nausea, vomiting, signs like that. Okay. Whenever there will be hyperphosphatemia, there will be because it will be binding with the ionized calcium, so it will lead to hypocalcemia as well. So signs will be similar to like hypocalcemia. Okay. So actually, this topic was I never studied. This topic was very difficult for me. I was just thinking, and usually it is not being asked. It's not a very frequent question because the things which are related to parathyroid hormone and vitamin D. Okay, so any comment or anything? Anyone want to add? Usman, any comments about phosphate?
Sir, the only question that is asked is refeeding syndrome regarding phosphate, nothing else.
Yes. So refeeding syndrome, how to avoid refeeding syndrome?
Sir, we have to give nutrition in stepwise way. We don't give nutrition if the patient is in prolonged starvation. You don't give the calculated calories at one immediately at one stance. You have to divide it. You give in a divided dose. Like if you give 50% and then gradually 25% and then 25% like this.
Yes, this is one of the way, and actually you will be continuously monitoring it. You will just and another way to avoid it is to start an infusion rather than bolus. Okay, so this will also be like okay. So hyperphosphatemia, acidosis, phosphate moves out of the cell, cytotoxic agent, renal failure. Okay, hypocalcemia, and the symptoms related to sign and symptoms which are mimicking hypocalcemia. Okay, management. In these cases, because usually it's related to either chelating. You are doing either chelating, or you are doing diuresis, or end will be dialysis. Okay, so this is the general principle for managing this thing. Okay, so any other thing, any other comment? Because I apologize because this topic is quite difficult. I just try to just explain in the possible way. With reference to just if we will just try to have a small whenever we have a patient on mechanical ventilation, and we just try to wean the patient off. Okay, so if we are not able to wean the patient off, so how will you approach? Like if you have a patient with for mechanical ventilation, of course the primary reason has been resolved. So it may be any reason. So primary reason is resolved. So how will you approach? Yes. Any clues? Like for example, the primary reason was head injury. Okay. And that when edema has been settled, but the patient is unable to be weaned off. So how will you approach? What things you can do? Any ideas, Usman?
Yes, sir. In a patient of head injury, sir.
For example,
Okay,
it is
sir.
actually related to weaning, but like causes.
Okay,
What are causes?
right,
Weaning.
right. Sir, first of all, yes, as you have mentioned that the primary pathology, be it a head injury or a ARDS or a pneumonia, anything, acidosis or low GCS or a trauma, that should be settled. The first of all, that the basic cause that should be settled one. The second is the patient should be hemodynamically stable. He should have adequate MAP. He should have no arrhythmias or hypotension, or he should not be in any double inotropes. One inotrop is acceptable, but he should not be on a double inotrop. And then, sir, if we look at the ABGs, the pH should be normal, and the patient should not be on acidosis or alkalosis. And the PO2 should be normal. There, it depends upon the FiO2. The minimum FiO2 should be required, and sir, otherwise PCO2 levels should be normal. Like the ABGs, you should have a normal picture. Then, sir, hemodynamically, we have told the patient then should have adequate GCS. Then if we look into
No, actually,
the parameters on the
Usman,
ventilators.
Usman,
Yes, sir.
sorry to interrupt you. Actually, my question was, what are the reason to failure from winning?
Okay. Reason for
So
failure.
you are telling the right things, that before winning, you have to see these things, that you have to check the hemodynamics, you have to check the mechanical functions of lungs and gaseous exchange function. Okay. And then you are seeing all the systems, that patient is making urine, patient is not on too much inotropes. So that if you are following these prerequisites, you will there will be chances that you are able to.
Right, sir. Okay, you
Now,
are
what
asking
would be
when
the
to
possible?
abort.
Yes, possible failure.
Okay.
Because one of them
Okay,
we have
sir.
discussed, hyperphosphatemia.
Yes,
One
sir.
of them,
Okay.
because
Okay.
this is leading to
Right, sir.
muscle weakness.
Right, sir. Yes, sir. If we after giving the spontaneous breathing trial SPT, if the respiratory rate is increased of like 30 more than 35, if SpO2 is less than 90, if the heart rate is more than 140, and if the blood pressure, systolic blood pressure is more than 180, and the patient is panic on having arrhythmias, sweating, anxiety, then I think you should abort and sedate the patient.
Yes. Yes, Mazama.
Sir, there could be other causes like critical illness, polyneuropathies,
Yes.
delirium, and electrolyte imbalance, ventilator-associated pneumonia could related to mechanical ventilation, which later lead to poor failure of winning trials.
Yes, like few of the electrolyte imbalance. One of them is hypophosphatemia, hypokalemia, okay, hypernatremia, hyponatremia. So electrolyte imbalance, ischiocord muscle weakness, delirium. Okay, so if you are not maintaining the homeostatic conditions, okay, homeostatic condition, so that will be the reason for delayed weaning. And then you will, of course, you will go one by one, step by step you will go. Okay, that you will be looking at the causes related to central nervous system. That will be with the neurological assessment as well as radiological assessment. Okay, radiologically, if there is anything, any signs of raised ICP or any cerebral edema or things like that, you will settle down. Then you will come down. Then you will be looking at any. You will try to avoid the factors which can lead to ventilator-associated pneumonia. Okay, so that will be your consideration. Then you will be going towards the lung protective strategies to avoid ARDS, and then you will be doing all the like sepsis, surviving sepsis bundles you will be doing. Then you will be doing the you will try to avoid the lines as much as possible. And if there are any signs of infection, because any source of infection you will try to rule, you will try to treat. Okay, and then like all the pressures in different chambers, whether it is intraocular pressure, whether it is intracranial pressure, whether it is intrathoracic pressure, whether it is intra-abdominal pressure. limb compartment pressure. So all of these factors will be important when you are trying to wean off the patient. Okay, then you will be giving the DVT prophylaxis, you are doing physiotherapy, you are just trying to maintain the patient in even balance rather than positive balance. And like this is actually general ICU care. So but when if you are failing to wean off the patient, your approach will be in that way. Okay, you will try to avoid all the factors which can lead to delirium. Like for example, if patient is hypothermic, that will be the factor for delirium and delayed metabolism. And if you have given medications which have prolonged elimination half-lives, like for example, the medication which we are giving a lot in Saudi Arabia, at least in Pakistan, we are giving midazolam or atracurium, and we are giving too much muscle relaxant. But if, for example, here, if with reference to Saudi Arabia, even fentanyl has very low circulation time, but it has prolonged elimination half-life. It takes so much time for elimination, because when the fat stores are already fully occupied, then even fentanyl will be a big cause for weaning failure. Okay, so if you like you have stopped everything on paper, you are saying no sedation, but still you are not able to wean off the patient. So one of the reason will be that one. Okay, so what medication you can use instead of midazolam and fentanyl if you want to wean off the patient? What medication can help you?
So dexmedetomidine.
Dexmedetomidine.
Very good. Dexmedetomidine. So dexmedetomidine, because it will not cause respiratory depression and respiratory weakness. So it will be a help, because it will be help for you. And if, for example, you are even propofol, like you have before, you are giving midazolam and fentanyl, now you want to wean off. So if for a small time you can stop other medication which have more metabolism and more elimination half-life as compared to the medication which have less elimination half-life. Okay, and you will be going gradually. You will try to avoid reintubation. Okay, because if you extubate early, there will be chances of reintubation. And if you see the data for ICU, in case of reintubation, mortality morbidity is more. Okay, so this is, I just try to correlate it with reference to hypophosphatemia. I have very less material to speak out about phosphate. Okay, so we will just take a break from this electrolyte. I am really bored and fed up. So I will start some new topic inshallah tomorrow, and maybe a case discussion sort of thing. Okay, so thanks a lot. Yes, yes, Dr. Dora.
Uh,
So I have a question regarding how often, is there any recommendation how often should phosphate levels be checked for example, mechanically ventilated patient in the ICU, or when we are starting maybe to
Actually, there is
refeed the patient?
I don't think so, Dora, that there will be any fixed recommendation for it. It will be individualized approach according to the patient. And for example, if the patient has some risk factors, which like patient with like alcoholic patients who have problems related to absorption, okay, or any patients like that in which there are risk factor that patient is maybe predisposed to hypophosphatemia. Okay, so then I think you will be doing more frequently, and once you diagnose it, then you will have to replace it. Whenever you are replacing these electrolytes, you have to do serial levels, I think. So that in that case, but I am not sure about any like specific recommendation with reference to it. I will just have a look. If I find any recommendation, I will share. Okay. Yes, Tayyab, you were asking something.
Thank you.
Sir, how to treat hypophosphatemia in this case of delayed weaning?
You will find out if it is the case. You will be replacing it. I think it is because I share with you that I am not working in ICU at least for 8 to 9 years now. So I even forget how to do it. Either they are doing it oral, okay, or IV. Okay, so you see it is written here. Give slowly, not faster than 10 milliequivalent per hour. Okay. So when we were discussing potassium, we said that there is sodium phosphate. If we have concomitant like both potassium and phosphate deficiency, so potassium phosphate is given. Okay.
Okay, sir. Thank you.
Okay, Tayyab. Okay, so thanks a lot all of you for joining, and like most probably, inshallah, I will just start with a case-based discussion. I will send the case tomorrow, inshallah. Okay, thank you. And after some time, then we will resume this topic because there are so many things still left. Acid-base balance is still left haunting me. Okay. So thank you very much. The recordings,
Thank
all
you.
the recordings for the whole of the electrolytes is there. And any questions, whenever you want to ask, you can ask through WhatsApp. Okay. Thank you. Bye bye.